Good evening, everyone. My name is Ira Mehta, and I'm a freshman at Lake Ridge Academy High School. My project was on the effect of high-volume hemofiltration for acute kidney injury in critically ill patients. High-volume hemofiltration is an extracorporeal therapy blood purification technique. Our goal was to assess the efficacy of high-volume hemofiltration, or HVHF, among patients with acute kidney injury, or AKI, and sepsis. We performed a literature search in PubMed and used different articles and sources in order to elucidate the role of HVHF in AKI and sepsis. All the studies were included if there was a need for HVHF, either for sepsis or AKI in critically ill patients. We analyzed a total of 809 patients from 11 different articles. 7 out of 11 studies showed an important improvement in patients' health after the patients received high-volume hemofiltration. 4 out of 11 patients showed no benefit of receiving HVHF. This review showed some evidence of benefit in a patient's survival after receiving HVHF, but there is insufficient evidence available in the literature to recommend the routine use of high-volume hemofiltration in critically ill patients. Further studies are needed to assess the efficacy of high-volume hemofiltration. Thank you.
Awesome, thank you for that, Ira. I'm going to hop right into it. So my name is Nikhil from Case Western Reserve University, and I'm presenting on a literature review and survey on telemedicine amongst pediatric nephrologists and their patients in North America during the COVID-19 pandemic. Our projects had 3 main goals. First, to look at existing literature to see how telemedicine has been used in the pediatric nephrologic population. Second, to release a survey to patients and providers alike to see how they've managed with the rapid implementation of telenephrology services in the wake of the current pandemic. And the third was to identify limitations and potentials for improvement in telemedicine services. While the literature review came back with very few articles and manuscripts on telemedicine use prior to the COVID-19 pandemic, our aim in regards to the survey was highly successful. We received over 400 survey results from providers, along with over 300 from patients. In terms of what we found from the survey results, it is very much what you would expect. Both patients and providers alike were appreciative of telemedicine services in order to stay safe during the COVID-19 pandemic. For patients especially, it's very useful for flexibility of getting in-person visits or getting visits in general, however, providers and patients alike struggled with the fact of getting physical laboratory results, and that requires a bit more maneuverability on the part of providers and patients to get those results. But for nephrology services, most of it is education and interpretation of symptoms more so than requiring a lot of lab results. So good clinical services were delivered. In terms of limitations, transmitting empathy to patients during provider visits was always a struggle, along with training on the new telemedicine services. However, in the future, this results is going to be useful in terms of establishing consensus guidelines, and that's currently being done by a group of internationally renowned physicians across the world through the Delphi method, and those results should be promising. Thank you.
Hello everyone, my name is Shamai and I'm presenting original research about common variable immunodeficiency, which despite being one of the most common primary immunodeficiencies is still poorly understood and underdiagnosed. Because of that, we conducted a study to find out if there's any easy marker which can be used by primary care physicians to raise suspicion of CVID. Our hypothesis was that recurrent infections could be used as a sign of underlying immunodeficiency. To test this hypothesis, we conducted retrospective case control study. We collected data on over 400 of patients who underwent immunoglobulin testing, and then looked at the number of office visits related to infectious processes in the year prior to testing. we discovered that there was a trend toward having a high number of such visits in patients with any type of immunoglobulin deficiency. However, this difference in our study was not statistically significant, most likely due to a small number of patients. We believe that a larger study would confirm this hypothesis, but in the meantime, at the very least, recurrent infections in any patient should raise suspicion of common variable immunodeficiency and initiate workup. Thank you.
Hello all, I'm Sohi, MS3 at NeoMed. My project is titled A Survey Analysis of Telehealth Access to Geriatric Patients During COVID-19. As you may know, telehealth allows providers to gain virtual intimacy with their patients while maintaining physical distance. We've seen a rise in telehealth after the onset of COVID-19 in particular, and a major disadvantage to telehealth is technical illiteracy. So to assess geriatric patient telehealth literacy in Northeast Ohio, a few of my colleagues and I surveyed geriatricians and providers at Summa Health in Akron City and the Direction Home in Akron. 100% of our participants stated that less than half their patients have access to mobile devices and tablets at home. 75% of the participants stated that greater than half their patients reside at home or in independent living facilities. 60% of participants use telehealth, of which more than 70% now see more than half their patients using telehealth during COVID-19 and after the onset. More than 80% of our providers stated that their patients feel severely uncomfortable using telehealth, and 90% stated that a volunteer-led program would actually help improve telehealth literacy and be extremely useful in their practice. So my colleagues and I are using this information to develop a student-led virtual program to better assist patients in using telehealth and improve patient compliance and health overall.
Hello, my name is Isabel Mobby, and I'm a second-year medical student at NeoMed, and I'm sure you're all well aware of our COVID-19 pandemic. So far, there's been little data collected on acute kidney injury, or AKI, in pediatric COVID-19 patients admitted to the ICU. AKI is a severe complication of COVID-19 among children and adolescents, so understanding all aspects of disease is crucial to further developing treatment and preventative care strategies to reduce morbidity and mortality. This is why our retrospective study aims to identify the epidemiology, associated risk factors, treatments, and mortality of AKI in pediatric COVID-19 patients less than 24 years old admitted to the ICU in North America. We're using the Virtual Pediatric Systems Database, or VPS for short. I'd like to note that while I'm presenting data from the VPS database, this is an ongoing study and additional VPS data is intended to be analyzed in the near future. Today, data regarding 1,240 pediatric COVID-19 patients was analyzed. Most significantly, 172 of these patients had renal or urinary system involvement. Of the 172 patients with renal involvement, there were 19 confirmed deaths. This means that 45% of all confirmed pediatric COVID-19 deaths were associated with renal involvement. This study is so significant because prior to this, there is not an existing large-scale study examining the extent of AKI in pediatric COVID-19 patients in North America. I'd like to conclude by saying that renal or urinary involvement among COVID-19 pediatric patients tends to be associated with high mortality. Please stay tuned as we continue to discover more about the manifestations of AKI and COVID in children using the VPS database.
Hello, my name is AIPNO, and my project was long-term renal outcomes in children with acute kidney injury post-cardiac surgery. Even though AKI has been shown to be associated with poor short-term outcomes, including mortality in multiple studies, the long-term renal outcomes in survivors of AKI in the pediatric and neonatal intensive care unit setting have been understudied. Our objective was to study the long-term renal outcomes and markers of kidney injury in pediatric patients who did and did not develop AKI following cardiac bypass surgery. We did a prospective case control observational study of all infants and children who underwent cardiac bypass surgery from December 2010 to December 2017 and had a long-term follow-up. Our evaluation consisted of estimated GFR, serum blood urea nitrogen, serum creatinine, urine albumin creatinine ratio, serum cystatin C levels, serum beta trace protein. Our urinary biomarkers consisted of NGAL, LFA-BP, KIM1, and IL-18. What we found was that in children with congenital heart disease, cardiopulmonary bypass time is significantly associated with the decrease in GFR and a rise in kidney injury biomarker KIM1 levels several months post-operatively independent of post-operative AKI.
Hello everyone, this is Amido Bawab, one of the internal medicine resident at St. Vincent Charity Medical Center. Today, I'm presenting a case of rare spontaneous urinary bladder rupture mimicking acute renal failure. So our case is 46 years old female, presented with a chief complaint of sharp stabbing, abdominal and pelvic pain for 1 week. CT scan was done and showed a slight amount of fluid in the pelvis, for which it was highly suspicion for ovarian cyst rupture. However, further workup was done and showed abnormal kidney function. In addition to that, large ascites and large pleural effusion. After that, multiple thoracentesis and paracentesis done. However, despite thoracentesis and paracentesis, fluid still reaccumulate over there. So subsequently, we did chest tube. Nephrology was consulted for abnormal kidney function test and he recommended biopsy. Biopsy was taken and it was completely normal. After pleural fluid analysis, it showed high creatinine. We consulted a neurosurgeon for which he did cystoscope and showed urinary bladder rupture. After that, intraperitoneal abdominal surgery was done and the rupture is repaired. After that, the patient dramatically improved and kidney function was dramatically improved and chest tube removed. Thank you so much.
Good evening, everyone. My name is Kanchi Patel, and I am a PGY1 at St. Vincent Charity Medical Center. Our poster highlights an unusual presentation of acute cholecystitis. Our patient was
Hi, everyone. My name is Ritika. So our case was a 3-year-old child who was diagnosed with steroid-dependent nephrotic syndrome (NS), and she started on prednisolone and mycophenolate mofetil therapy (MMF) with parental consent and was lost to follow-up. So 4 months later, she had 2 weeks of high fevers that varied between 38 to 40 degrees Celsius with hepatosplenomegaly and leukocytosis. So we started different treatments with intravenous ceftriaxone and doses of prednisolone. So then after that, we took tests and we evaluated them, such as blood and urine, serologic testing, echocardiograms, chest x-ray, ultrasounds, pediatric hematology review, and bone marrow studies. And finally, a computed tomography scan of the chest. So all tests showed all normal results with no abnormalities, but the computed tomography scan of the chest in figure 1 showed hepatosplenomegaly and diffuse ground glass haze in both lungs, which is significant because usually healthy lungs are clear. So further investigation showed levels in different tests, such as the total leukocyte counts, which indicated liver damage or deterioration. Furthermore, we took a polymerase chain reaction PCR test for cytomegalovirus, CMV, and the DNA revealed 56,340 copies per ml, which eventually did decrease to 180 copies after stopping MMF, including the institution of intravenous ganciclovir therapy. So after another PCR test was negative for CMV, she was then switched to valganciclovir and then turned out to be completely asymptomatic with undetectable viremia, a normal leukocyte count, and no organomegaly. All in all, the child is currently in remission for the last 6 months with no immunosuppressive therapy, and we suggest that persistently febrile pediatric patients with recent immunosuppression should be screened for atypical mixed infections such as mycoplasma. Thank you.
Good evening, everyone. My name is Kanchi Patel, and I'm a PGY1 at St. Vincent Charity Medical Center. Our poster highlights an unusual presentation of acute cholecystitis. Our patient was a 55-year-old male who presented with retrosternal chest pain and diaphoresis. EKG showed sinus bradycardia of 42 beats per minute. These symptoms were concerning for a possible inferior wall MI. However, troponins were negative and cardiac pathology was ruled out. On day 2 of admission, the patient developed severe epigastric abdominal pain. We ordered an abdominal ultrasound, which gave the impression of acute cholecystitis. Acute cholecystitis may mimic cardiovascular disease and rarely present as bradycardia, which is clinically termed as the Cope sign. The mechanism behind this pathophysiology is not clearly understood till date. However, it is thought that the inflamed gallbladder causes vagal stimulation, which by its cardioinhibitory response leads to bradycardia. So to sum it up, the gallbladder-associated conduction delays, also called cardiobiliary reflex, can be life-threatening, and these patients should be managed cautiously to avoid fatal complications. Thank you.
Hi, everyone. My name is Divya Sharma, and I'm a medical student from NeoMed. Good evening. My poster is about eculizumab in the management of gemcitabine-induced hemolytic uremic syndrome. So our case was about a 64-year-old female who presented with recurrent abdominal pain with pale stool. After an appropriate workup, she was diagnosed with an unresectable 4-centimeter adenocarcinoma of the pancreas. She was started on a chemotherapeutic course of 3 cycles of IV gemcitabine therapy at 1,000 milligrams per square meter. And 1 month following initiation of gemcitabine, she developed microangiopathic hemolysis with proteinuria, hematuria, and rapidly declining renal function. So to treat that, she first got continuous renal replacement therapy, then conventional hemodialysis, and also 6 cycles of plasmapheresis using albumin, but those didn't show any response to the gemcitabine-induced hemolytic uremic syndrome. She was then started on eculizumab with 1 dose every week initially and transitioned to 1 dose every month for a total of 9 doses. Her creatinine clearance improved significantly after the eculizumab therapy from 14 to 60, and her markers of hemolysis also improved, which included LDH and bilirubin. So in conclusion, further investigation about the risk factors of gemcitabine-induced hemolytic uremic syndrome is warranted. The dramatic resolution of symptoms after eculizumab administration suggests that the mechanism may be related to complement, and it needs further investigation. And finally, a larger scale trial needs to be done to show how effective eculizumab is in treating atypical hemolytic uremic syndrome. Thank you.
Hi everyone, I'm Hirva. I'm an M4 at NeoMed. To preface this presentation, my poster is based on a lit review that I recently co-authored. So in the US Renal Data System's 2019 report, the prevalence of end-stage renal disease, or ESRD in children, was 98.7 per million population. Kidney transplantation is the preferred treatment for pediatric patients with ESRD, but because of a supply-demand mismatch, hemodialysis is begun as a bridging therapy. Reliable vascular access is essential for proper hemodialysis. The main modalities of vascular access are central venous catheters, arteriovenous fistulas, and arteriovenous grafts. Catheters are currently the most commonly used for both emergent and long-term dialysis. Complications of use include pneumothorax, thromboembolism, infection, and venous stenosis. Fistulas are actually the ideal mode of vascular access for prolonged dialysis. However, they do require 1 to 3 months for maturation. Infection is much less common in fistulas than in catheters. The International Pediatric Hemodialysis Network, which analyzed 550 patients with various modes of vascular access, showed that there were no infectious complications with fistulas, while catheters had a rate of 1.3 infections per 1,000 catheter days. Compared to fistulas, grafts have higher infection, thrombosis, and stenosis rates, but they do have a lower incidence of primary failure and a substantially higher patency rate at 1 year after placement, as seen in Sheth's data. One of Dr. Reyna's previous studies found that grafts were half as likely to have primary failure compared to fistulas, but unfortunately had 3 times the rate of secondary failure as fistulas. Given all of this data, fistulas appear to be the optimal method of vascular access for pediatric hemodialysis over the long term. Within the next decade, we hope to see the use of fistulas in children undergoing dialysis increase exponentially. Thank you.
Hello, I'm Nikita Kumar, and I'm presenting on the use of RAI for acute injury. So the use of a renal angina index (RAI) to calculate and accurately predict risk for development of acute kidney injury has been heavily explored in recent years. AKI is traditionally diagnosed by an increase in serum creatinine concentration or oliguria, but these are neither specific nor sensitive, especially among children. An RAI score takes into account both the objective sign of kidney dysfunction and patient context. And some of these are ICU admissions, diabetes, transplantation, and therefore it becomes a more accurate biomarker for AKI. Since RAI is novel, this systematic review aims to analyze how well RAI serves as a predictor of AKI outcomes. A comprehensive literature search was conducted in PubMed and Google Scholar. And by looking at this, we only included, even though there were 149 studies in the initial literature search, we only included 10 because those had they included the prognosis aspect of early prediction of AKI in pediatric and adult populations via renal angina index versus creatinine. And so from this, there was a sample size of 11,026 across all the studies that we included. And with a 95% confidence interval, there's a sensitivity of 79.21% and a specificity of 73.22%. And with all these, all of these articles, we found that there were observed to have, RAI positive patients were observed to have a 4.5 times higher odds of mortality as compared to RAI negative patients. And so with this, we can see that RAI is definitely a better use, a better risk stratifies patients and predicts mortality. And therefore it is more sensitive and more specific, especially for children than creatinine levels, and therefore that's the way that we should continue. And without RAI, clinicians lack a way to risk stratify patients. Thank you.
Hello, good afternoon, everyone. I'm Francisco Somoza. I'm a PGY1 in San Vincent Charity Medical Center. I want to present an interesting case about delirium tremens and acute coronary syndrome. We did this in conjunction with Dr. Alarmashi. So as we very well know, delirium tremens is one of the most dangerous complications of acute withdrawal. Moreover, the chronic alcohol use that these patients have produce microvascular damage to the microvasculature of the heart, impairing vasodilation when needed. A 63-year-old, he presented to our ED with chest pain and shortness of breath, past medical history of alcohol use disorder and cocaine. On admission, he was with hypertension and tachycardia. Other than that, the labs showed trending troponins and an ECG with new table inversions compared to an ECG done 1 month prior. UTOX was positive for cocaine. So we admitted that patient as a type 2 MI, has a demand ischemia to the ICU and gave management. However, 48 hours after admission, he started having hallucinations. tachycardia and hypertension. He was already on an Ativan protocol, but this was found to be insufficient. So a Pressotec strip was started. 8 hours after this, he started complaining. Well, he didn't had any complaints, but we noticed changes in the telemetry strip. New troponins showed that they were trending up, and repeat ECGs showed new left bundle branch block and SD segment elevations. The patient never complained of chest pain, nor he had any other complaints. He was actively hallucinating. So we just wanted to present this case with a complicated patient, showing that delirium tremens may mask the signs that we usually look for in a STEMI, especially if they're on heavy sedation, such as this patient. Or yes, thank you very much.
Good evening.
Swati Jyoti.
This is Kanchi Patel, and I am a PGY1 at St. Vincent Medical Center. Our poster highlights the rare metastatic spread of glycogen-rich clear cell breast carcinoma to the stomach. Our patient was a 75-year-old female who presented with dizziness and unsteady gait. Physical examination revealed unilateral hemiparesis, and MRI showed subacute stroke. Given these findings, she was started on dual antiplatelet therapy. However, 2 days following admission, she was found to have a hemoglobin of 5.8. An EGT was done, which showed fungating ulcers in the stomach, and the biopsy specimen revealed poorly differentiated adenocarcinoma consistent with her primary breast tumor. She was diagnosed as stage 4 metastatic invasive breast carcinoma. This is important because the stomach is a very unusual site for breast cancer metastasis. And there are 3 pathways that are possibly involved in this spread: hematogenous, lymphatic, or direct tumor invasion, all of which have a very poor prognosis. The non-specific symptoms of dizziness, unsteady gait, and low hemoglobin, as seen in this patient, were all secondary to the unusual mets of breast cancer to the stomach. This case is significant because gastric mets have a very negative impact in patients with breast cancer. Therefore, there should be a very high index of suspicion, even if the symptoms are vague. Thank you.
Good evening. My name is Swati Jyoti. My poster is on creating guidelines to manage recurrent focal segmental glomerulosclerosis. RFSGS is the most common cause of recurrent nephrotic syndrome in the post-transplant period and is a significant cause of mortality and morbidity in these patients. Hence, we did a systematic review and meta-analysis to formulate guidelines on managing this entity. We gathered 614 papers from Embase, Cochrane, and Medline databases, and we narrowed it down to 221 through our strict exclusion criteria. We then extracted data and performed a meta-analysis. We identified the incidence rates for RFSGS, which was then stratified by age, sex, race, donor type, and acute rejection episodes. We also narrowed down the common risk factors for developing the recurrent disease. We also explored various treatment options and did a meta-analysis on rituximab, as it is the most promising in maintaining remission after therapeutic plasmapheresis. We then condensed this information and detailed it as guidelines in the discussion section. Thank you.
Hi, everyone. Good afternoon. My name is Bhavya Sharma, and I'm a third year at NeoMed. And I'm going to be talking about a case report of a benign co-secreting unilateral adrenal adenoma. So as an introduction, adrenal adenomas are relatively common benign masses that are most often inactive in hormone secretion. These tumors do not ordinarily cause symptoms and are regularly incidental findings on imaging. Most of the time, they don't secrete any hormones. It's rare for them to secrete one, and it's even more rare for them to be co-secreting. So the case itself, a 56-year-old woman with a 5-year history of hypertension, recently diagnosed with type 2 diabetes, was admitted for acute decompensated heart failure with preserved ejection fraction of 64%. Significant medical history include uncontrolled hypertension despite multiple medications. She was found to have profound hypoglycemia despite supplement of 80 milliequivalents per day. She has a history of frequent admission for acute diastolic heart failure due to hypertensive crisis, and blood pressure admission was 190/100. So workup and management, nephrology was consulted for hypokalemia and uncontrolled hypertension. Transtubular potassium gradient was assessed to evaluate excess mineralocorticoid bioactivity in the distal nephron, and the TDKG values were greater than 6 in the presence of hyperkalemia, indicating excess mineralocorticoid activity. Serum aldosterone concentration was higher than normal with low plasmapheresis activity while on lisinopril, and early morning serum cortisol was found to be 14. Abdominal CT scan displayed a right adrenal nodule with calcifications and a density of 18 Hounsfield units. To address the resistant hypertension, spironolactone 50 milligram twice daily was used with marked improvement in blood pressure and hyperkalemia. So as a summary, this patient had history of severe hypertension and hypokalemia, which was initially attributed to excess aldosterone activity. After observing the size of the tumor on imaging, our index of suspicion for cortisol production was high, and additional adrenal adenoma workup confirmed the presence of subclinical hypercortisolism, and excess glucocorticoid production was then the attributable cause of the patient's new onset diabetes and obesity. So here's a CT scan of what a right adrenal calcification would look like. And as final thoughts, benign adrenal adenomas can co-secrete excess aldosterone and cortisol, which can change clinical management. Thank you.
Hello, everyone. I'm Nirav Agrawal. My topic is on extracorporeal anticoagulants in pediatric continuous kidney replacement therapy. As we know, for the kidney replacement therapy is broadly used to stabilize the patient with severe AKI, toxic ingestions, fluid overload. And especially when it comes to pediatric, we have to take extra precaution when we are using anticoagulants. So we did a meta-analysis going through all the suitable anticoagulants available. And the most common anticoagulants used were heparin, RCA, and prostacyclin. As we know, all the anticoagulants had some positives and some negatives. When we're selecting an anticoagulant, we have to see the safety and the efficacy of it. So that was the main purpose of our meta-analysis. So we went through literature search, doing PubMed, Medline, and Google Scholar, and we came up around 60 studies. And the meta-analysis was done on 35 studies. And based on that, we came to a conclusion that when it comes to safety, there is not much difference between renal citrate and heparin, but when it comes to efficacy, there is a longest circuit lifespan for citrate compared to heparin. And so ideally speaking, if somebody have to select in an ideal situation, if there is no contraindication for citrate, that's the best medication, that's the best anticoagulant to go with in pediatric CKRT. But if there are any contraindications, unfractionated heparin will be the best next choice. And yes, thank you.
Hi, this is Aditi. I'm unable to share my screen. go. Hi, sorry for delay. I'm Aditi Mittal. I'm a first-year pediatric GI fellow at Cleveland Clinic, a former resident of Metro Health Medical Center. I'm presenting my research study on H. pylori infection in children in an urban Midwestern US health system. And we wanted to study this infection both at the individual level as well as at the population health level. As we know, H. pylori is an important cause of peptic ulcer disease and gastric cancer worldwide. We know there are the high risk groups in adults like African American, Hispanics, and poor socioeconomic status, but little data about that in children. So we wanted to study both on the individual as well as the population health perspective, all the socio-demographic factors. So it's a retrospective cohort study. This includes children less than 18 years of age who were living in Cuyahoga County, who were tested for H. pylori at Metro Health Medical Center from 2009 to 2017. We obtained the various demographic factors, as well as we studied them on a system called Geographic Information System, which uses ARCMap, and we mapped it down all the H. pylori infection patients, which their address on the census tract level, as well as the socio-demographic factors, and studied the correlation. So out of the 1380 patients that we had, 16.4% were tested positive for infection. And on the univariate analysis, H. pylori positive cases had older age, female gender, had African American race and government insurance status, as well as anemia. But on multivariate analysis, which used the logistic regression, only older age, African American race, and government insurance status was significant for H. pylori positive status, whereas interestingly, English as the primary language spoken at home was considered to be a protective factor for H. pylori infection with an odds ratio of less than 1. We did map it out on our census tract level and found a very strong correlation of H. pylori infection with poverty in general, as well as poverty in children. However, there was no correlation in the foreign-born status. So what we conclude from this study is that H. pylori positive status in children is also associated with African American race, government insurance status. And interestingly, English as a preferred language spoken at home could be protective, which could be a surrogate marker of foreign-born status, however, was not visible on our population level. And on the census tract level, though, there was a significant correlation with the child poverty and H. pylori positive status. So this study would definitely help us in identifying and treating high-risk groups earlier, and we could possibly develop some public health focused interventions to reduce H. pylori infection in families and communities. Thank you so much.
Hi, this is Abhinaya Ilagovan. I'm a fourth-year medicine pediatric resident in Metro Health Medical Center. So this is a project on fecal immunochemical tests at a urban safety net hospital. The requirement of clinic visits to order and obtain fit testing is perceived as a barrier to complete colorectal cancer screening. So we devised a population health level strategy to bulk order fit kits on patients who are eligible. So for this study, we devised electronic health record strategy in our EPIC record, health record, which will identify individuals between 50 and 75 years of age and who are due for fit screening. So this goes on an automated basis every day. Once a month, the population health staff will place orders on those individuals who had a primary care visit and a primary care provider within the Metro Health system in the last 2 years. So after about 8 months of the study, we analyzed the data from bulk ordering fit and compared it to fit kits placed through regular orders through clinic visits. We found that the regular orders placed in clinic visits had a higher rate of release, which is many people got the fit kits and most people completed it. However, in bulk ordering method, there was a higher percentage of follow-up after a positive fit. What is exciting about this project is that this project is time efficient, it's zero cost, and we identify individuals who are due for screening even before they go to the clinic. So interventions such as this one is very accessible and can be developed in any healthcare system. Thank you. So this is my next study on high burden of obesity and low rates of weight loss pharmacotherapy in inflammatory bowel disease. So we all know obesity has been increasing in all healthcare groups, and IBD is no exception. So for this purpose, for this study, we used a retrospective commercial database that's called IBM Explorers. This database pools data from about 26 healthcare networks in the US. We identified individuals who were adults who had diagnosis of IBD and a BMI greater than 30 in the last 10 years. We excluded the conditions that were contraindications for prescription of weight loss pharmacotherapy. We looked at medications that are approved for short-term use by the FDA, as well as those which are approved for long-term use. We found that about 78,200 adults with IBD and obesity were eligible for treatment. Among them, only 2.8% of adults were prescribed the pharmacotherapy. Phentermine was most common drug with about 75%. This was followed by naltrexone, bupropion, which were prescribed in 15% of these individuals. We found that women, people under the age of 50, African Americans, and those with insurance other than Medicare were more likely to be prescribed this therapy. We analyzed the trends over the last 10 years. We found that there was a decrease in this therapy between 2010 and 2012, following which there was an increase. We hypothesized that this decrease could be due to the withdrawal of sibutramine in 2010. We should also recognize that lorcaserin was discontinued by FDA in Feb of this year, which could have an eventual impact. We conclude that despite the high rates of obesity in IBD, a very small percentage, about 2.8%, is prescribed weight loss pharmacotherapy. Efforts to understand and analyze the barriers to therapeutic management of obesity can help us overcome this pandemic in IBD.
Okay, this is Shamai Kurbitayeva again. I'm presenting another original research about adverse reactions caused by prolonged wearing of face masks amidst COVID-19 pandemic. As you all know, in order to slow transmission of COVID-19, millions of healthcare workers were forced to wear some type of face mask for unusually prolonged periods of time. And except for a few observational experimental studies, the consequences of this practice were not investigated. We sent an anonymous 10-question survey to all employees of our hospital, St. Vincent Charity Medical Center, with various questions regarding face masks. 95% of responders reported having at least one adverse reaction. The most common reactions were skin rash, including rosacea, acne, eczema, etc. Other common reactions were shortness of breath, nasal congestion or dryness, ear pain, headache, anxiety, sore throat, sweating. Social and communication issues, which included inability to express emotion, were also very common. Half of participants rated these adverse reactions to have at least moderate effect on their quality of life. And interestingly, 42% said that they would not wear a mask if it was not required by the hospital. We think that further studies are needed to investigate this subject because identifying adverse reactions and finding ways to prevent them or mitigate them at least is not only important to improve persons' comfort while wearing a mask, but also compliance with mask wearing. Thank you.
Hi, my name is Ranjit Vallabhreddy. I'm one of the residents at St. Vincent Charity Medical Center. So today we are presenting a case report on a 31-year-old male who was admitted for the 4-day history of progressive worsening watery diarrhea, abdominal pain, nausea, and vomiting associated with on and off fever and chills. Stool was found smelling and had abdominal cramping before and during bowel movements. He denied any mucus or blood in the stools, recent antibiotic use or hospitalization, consumption of outside food or similar complaints anyone in the family members. So physical examination was significant for hyperactive bowel sounds.
Hi everyone, my name is Nikhil and I'm an MS3 at NeoMed, and I, along with Prajeet Kubal, who's also on this call, performed research on right ventricular dysfunction, primarily in African Americans. So we worked with Dr. Cassis George, who practices as an interventional cardiologist, and she noticed in her clinic that African American patients with heart failure, whether it was with reduced or preserved ejection fraction, seemed to have more significant right ventricular failure or dysfunction, even with moderate pulmonary hypertension compared to their Caucasian cohorts. So we performed a study that included 64 patients who were 70% white and 30% African American from St. Elizabeth Hospital in Youngstown and Allegheny Hospital in Pittsburgh who had HFpEF or HFrEF with RV dysfunction. So the results from the right heart cath showed that African American patients suffered from heart failure primarily because of their PAH phenotype. This is significant because the leading cause of right ventricular dysfunction stems from left heart failure, as was shown by the Caucasian cohort of this study. So now the question is whether the results of the right ventricular dysfunction is primarily from right ventricular hypertrophy due to pulmonary hypertension, or if there's an unaccounted genetic difference in African Americans that explains these results. And that's what Prajeet and I are, and along with the rest of our team, are investigating currently. Thank you.
Okay, take a look at the chat, please. The following people that I list in the chat, can you please shift to research room 1? Exactly at 5, this room needs to be closed for the rest of the gala. So starting with Arvind, can you guys please move to the next or other research room? Thank you.
Hi, good afternoon, everyone. I'm Maitri Mudireddy, one of the internal medicine residents at St. Vincent Charity Medical Center. Today, I'm presenting an interesting case we encountered recently. My patient is a 37-year-old female with past medical history of hypertension, abnormal uterine bleeding, and she presented with a slurred speech, right upper extremity, and right facial numbness for an hour. Her symptoms resolved shortly after arriving to our emergency department. However, she was evaluated for stroke in the emergency department and admitted to regular nursing for further management of her abnormal labs. On the initial evaluation, her physical examination was significant for elevated blood pressure and active vaginal bleeding. Otherwise, it was unremarkable, and her labs presentation showed hemoglobin of 8, thrombocytopenia of 59. So we found immediately after seeing the patient, we found answer for anemia as abnormal uterine bleeding, but she was further evaluated for her unusual presentation of thrombocytopenia, and following lab showed her haptoglobin was less than 8, which was very low, and elevated lactate dehydrogenase. And peripheral blood smear interestingly showed numerous histiocytes and nucleated RBCs and suggestive for microangiopathic hemolytic anemia. And the preliminary diagnosis of thrombotic thrombocytopenic purpura, which is nothing but TTP, was made, and patient received IV steroids and 2 units of fresh virgin plasma, and was transferred to tertiary care center for further management with plasma apheresis. So my case actually exemplifies the unusual presentation of TTP, and because it was very emergency condition all the time with mortality rate of 90%. And interestingly, Adams T13 levels that was collected at the time of the presentation was measured less than 0.2. After receiving a plasma apheresis at tertiary care center, immediately she was responded, and her platelet count increased from 59 to 410, and Adams levels also increased from 2% to 40%. Thank you very much.
All right, thank you. We're closing this room, and then you can go to the other group. Thank you.